morning and welcome to Psychiatry Grand Rounds. It's my pleasure to introduce today my good friend and colleague, Dr. Keith White. Dr. White is a fifth-generation Texan from Waco, Texas. He attended Texas A&M University where he majored in biology. For his undergraduate research, he worked with Michael Mason to help elucidate the structure and function of transmembrane chemoreceptors in E. coli. Dr. White is a graduate of the St. George's University College of Medicine, and he was in the Keith B. Taylor Global Scholars Program, where he received his diploma of higher education from Northumbria University. He completed his clinical training at the Long Island College Hospital and Kings County Hospital in Brooklyn, New York. He's currently a PGY3 resident and was recently a co-author in Challenging Office Cases in Obstetrics and Gynecology, where his work included evaluation of a suicidal patient in the outpatient setting. Today, Dr. White will be presenting Atypical Drugs of Abuse, the Zebras of Addiction. Dr. White.
Thank you, Dr. Lujan. You guys hear me all right? Also, before I forget, I'd like to thank Dr. Donald Henson. He's attending, actually, sort of the head of the Substance Use Dependency Program over at Mountain Home VA. And he has a full panel this morning, so he's not available, but he sends his love. So this talk was born out of my 3 years of experience here in East Tennessee. If anyone has spent any amount of time with patients in a clinical setting, they're well aware of the pill problem that we have in this part of the country, especially East Tennessee, and Johnson City is one of the probably meccas of drug use in this part of the country. I think what is not really talked about is some of the oddball drugs that I have seen in my 3 years of training that I think as the state of Tennessee and the federal government begins to crack down, we're going to see emerging trends of abuse of pharmaceutical drugs, not high-potency benzodiazepines and narcotic pain pills. So, I do own a little bit of stock in Cellside Corporation. It's a biotech company that does work on head and neck cancer primarily and swine flu. They don't make any psychotherapeutic agents. Also, I'm going to discuss off-label use of psychotropic medications and other agents. Of course, I do not endorse off-label use unless clinically indicated and you know your patient. So goals and objectives include identifying drug use and misuse in America, and particularly this part of the country. We're going to highlight some recent changes in state and federal legislation aimed at reducing drug use. Going to examine published literature and experiential reports to look at emerging trends, look at current and emerging trends. Also going to do a minimal overview of the psychopharmacology of the agents we're going to talk about today, and learn the clinical implications of misuse of these drugs. So America loves drugs, and this slide is meant to illustrate that. In 2011, which is the most recent data we have available, more than 4 billion prescriptions were written. Last 30 days, half of Americans have taken a prescription drug. About 20% have taken at least 3 in the last month, and about 10% have an active script for 5 or more prescription drugs. So we like our drugs. And this doesn't even include the more than 1 trillion pack units sold per year in the United States. To illustrate this, I have listed the 5 most common purchased over-the-counter classes: cold, analgesics, antacids, laxatives, diarrhea remedies. But there are many, many more over-the-counter agents that are purchased every year that have potential for abuse. So about 5.5% of all hospitalizations in America are related to pharmaceutical misadventure. Of that 5.5%, about 0.5% is a result of misadventure with over-the-counter agents. 2004-2005 data from the CDC shows that 70,000 children annually were brought to emergency departments, roughly 1/3 of these cases being a result of over-the-counter medication misadventure. It's a leading cause of injury, death in the United States in the past few years. It has surpassed automobile accidents. In the past roughly decade, overdoses in women has increased 400% among women and 265% among men, which is just a real startling number to look at. 113 people die a day as a result of overdose, and another 6,700 or so are seen in emergency departments for misuse or abuse of drugs. Of the 2011 pharmaceutical-related overdose abuse deaths, about 74% were unintentional, about roughly 20% were suicides, and 8.4% undetermined. 9 out of 10 poisoning deaths in this country are drugs. This is data from the Youth Behaviors Risk Survey that's done by public school kiddos every year, and this is the data from 2011 that indicates here in Tennessee, roughly 20% of high school students have misused a prescription drug within the past year, which is kind of an astounding number. Of course, everyone knows we're in the top 10 for drug misuse in America, and the National Substance Use Database here indicates that in those aged 12 and older, in 2012, roughly 2.5 million used psychotherapeutics non-medically for the first time, which is about 6,700 a day. Now, recently enacted legislation has been put in place to curb what I see as misuse of benzodiazepines and high-potency narcotic pain pills. Residents and clinicians that are prescribing now would know about the 2012 Prescription Safety Drug Act that mandated we, as prescribers, check the controlled substance medicine database generally for all controlled substances if prescribing a new medication, and within a year if we are continuing a controlled substance. Year down the road from that act sets a limit on the amount of Schedule II and III drugs that can be dispensed at a given time. It used to be sort of unlimited. Now it's 30 days. That's the most. Even if a doctor writes dispense 90 days, a pharmacy is not allowed to do so. So that's another hoop that drug users or people that are prescribed narcotic pain pills or opiates that divert them, that's another hoop that they have to jump through. As a result of the CSMD, the Controlled Substance Medical Database Act, significant increase, something like 350,000 compared from 2011 to 2012, which means that doctors are looking at what their patients are being prescribed. Database is also increasingly used by law enforcement. We saw roughly a 4-fold increase from 2011 to 2012, which is also helping to deter would-be misusers or abusers from getting their hands on drugs. Also, starting this year, new law enacted requires that dispensers report to the CSMD within 1 business day. It used to be 7. So now you can't have someone that goes on a doctor shopping bender for a 7-day period. Now it's limited to really 1 day. This also enacted this year limits the amount of ephedrine or pseudoephedrine you can purchase over the course of a year or in a single time, which I would hope is going to reduce the use of methamphetamine, just supply and demand reasons there. Also here, underage would-be purchasers can no longer get their hands on it. And this is about a half step in the direction towards what was done in Oregon, which has significantly reduced methamphetamine use and discovery of clandestine meth labs. They put pseudoephedrine and ephedrine on a controlled substance list, so you had to have a doctor's prescription. And between 2004 and 2008, they saw 400 lab incidents go down to 20, and of those 20, more than half were at the state's border, and they were dump sites. So what I would hope is this recently enacted legislation would reduce the supply of precursors for methamphetamine, in theory resulting in a reduction of methamphetamine use, which in my mind, would lead to them misusing other things. So I'm a firm believer it's pretty effective. So after those sobering statistics, I'd like to start with the first agent. It's Seroquel. Quetiapine is its generic name. It's a second-generation antipsychotic approved in the 90s for mood disorders, primarily bipolar disorder, adjuvant for depression and schizophrenia. We use it off-label quite a bit for PTSD, generalized anxiety disorder, patients' Parkinson's disease because it won't exacerbate their Parkinsonism type movements. We also use it in sundowners in patients with dementia. It's generally highly sedating, and it is gaining popularity among drug users because it is so sedating. Right now it's not scheduled. I don't anticipate it going scheduled. This is just to illustrate what a shotgun of a medication this is. It has a very wide receptor profile affinity, and these are just the highest affinity. It has actually another 20 more receptors that it binds. I've heard it called crackhead Ambien, jailhouse heroin, some terms that I found on the internet, Suzy Q, Q-ball when used in combination with cocaine. So it's now replacing heroin in the speedball, and they're calling it a Q-ball. Smoked with marijuana, and this is typically in youths, adolescents. They're smoking it with marijuana to potentiate the effects of marijuana. It can be taken orally. You can crush and snort it. You can smoke it. You can inject it. I've had patients that have injected it in the past for its sedative properties. It's generally got a low street value, and it is widely available, and I think its availability is kept the street value low. In fact, it probably costs more if you were paying out of pocket at a pharmacy than it is on the street. Thankfully, this medication has a very high LD50, which is lethal dose, at which 50% of people who take that dose die. And this was the lowest one. I think it was in rats, but in mice and no, this was in rabbits. In mice and in rats, it was greater than 5,000 mg per kg. I've had a lot of people overdose on this and not die, thankfully. So there's a manuscript that's been accepted to the Journal of Substance Abuse and Treatment that looked at atypical antipsychotic use at a large teaching hospital in New York. I think it was Beth Israel that they looked at. And of the inpatients that they screened, about 17% reported misuse of an antipsychotic with another agent, be it alcohol, cocaine, opiates, meth, or marijuana. And about 9% had done so within the last year. And of all those screened, 96% said that they misused Seroquel. About half got it from their doctor and half got it from family and friends. Reasons for use included to recover from benders, to enhance the effects of other substances, or just to experiment. And what the most positive effect reported was feeling mellow. Negative effects being consistent with second-generation antipsychotics. I don't know if anyone's felt like that about Seroquel. Now, this is bupropion, Wellbutrin, Zyban. Bupropion, generic name, Wellbutrin, is indicated for depression, and Zyban is the trade name for the smoking cessation aid. It's structurally similar to amphetamines. It is the most commonly abused antidepressant on the market. It is a general catecholamine uptake reinhibitor, and its antidepressant effects are typically thought to be related to its dopaminergic and noradrenergic effects in the brain. It is gaining popularity amongst prescribers because it has since gone generic I think in 2007 or 2008. And as a result of that, we've seen a 77% increase between 2009 and 2011. And it's 77% increase of all of the top 25 psychotropic medications on the market. So it's gaining in popularity, and it's easy to get your hands on. Now, when taken orally, there's no clear evidence for abuse potential in the general population. There is one study that I've been able to find that in those patients with a history of substance abuse, 400 milligram oral doses did produce mild stimulant-like subjective changes. It's commonly prescribed to inmates, especially after a lot of these federal facilities and local prisons started going tobacco-free. You could no longer smoke. What did they do? They prescribed them Zyban, and if addicts are nothing else, they're innovative. And if you have an inmate that has a lot of time on their hands, they're going to experiment with things. That or they feign depression to get it. Several case reports here locally of IV use. Dr. Stephen Ingram across the street at Woodridge has reported one here recently. The thing about this is it's typically insufflated, and that can be expected to skip that first pass metabolism and result in higher CSF and higher serum concentrations. Chemical euphoria, similar to that, attained from cocaine, and that's why they're calling it poor man's cocaine. Now, I have had a patient in the domiciliary who had a history of stimulant use disorder, and this was his drug of choice to get around urine drug screens, because this isn't an agent that we typically check for. He had an outside prescription from a primary care doc that had no clue he was a resident in the domiciliary, and he did this for, I think, a couple months until he fessed up to it. Next agent is gabapentin, trade name is Neurontin. This was improved in 2002 for epilepsy post-herpetic neuralgia. There we go. Commonly prescribed off-label for neuropathic pain and adjuvant mood stabilization. They're called GABIs. Mechanism of action is not clear. We know that it doesn't bind GABA. It is not converted into anything that binds GABA. And so its mechanism of action, the short story, is unclear. It is in the top 100 most prescribed drugs in America, and its effect profile is generally sedating. Currently not a scheduled drug, and because it's so commonly prescribed, it's got a very low street value. Now, when Dr. Melton across the street at the ETSU School of Pharmacy was asked by the Medscape Multi-Specialty Ask the Pharmacist publication on the Medscape website whether or not gabapentin had become a drug of abuse, this was her response. Not currently controlled, indicating that there's little potential for abuse, but it shares very similar characteristics of medications that are associated with misuse and addiction in that it produces a withdrawal syndrome. And it has certain psychoactive effects like causing euphoria or improved sociability. Some have reported marijuana-like high or a sense of calm. Others have reported feeling zombie-like. Now this is kind of a really funny report out of Florida. 2004, there was a recall by the maker of gabapentin. In this correctional facility, they attempted to get the prescriptions back from the inmates who had been allowed to manage their own medications because they're not controlled. Of the 96 prescriptions, only 19 of them had been found in the hands of the person to which it's prescribed. And so most of the guys that they got to talk with them about it in the report admitted to using it to get high. She also cites another study out of a methadone program where 22% of respondents reported using non-prescribed gabapentin in large part to potentiate the effects of methadone. So, and anecdotally, I had a gentleman across the street at Woodridge who liked to smoke and freebase gabapentin, and initially we thought he was smoking crack because he had burned fingers, but we did some qualitative studies, and we found out he had extremely high levels of gabapentin, not cocaine or methamphetamine. This is a kissing cousin of gabapentin. Again, this mechanism of action is not entirely clear. It was approved in 2004 for epilepsy, post-herpetic, I keep fumbling on that word, PHN, diabetic neuropathy, fibromyalgia. In Europe, they use it for GAD, and here we use it off-label, probably more frequently off-label than for the indications, for neuropathic pain. A review of arrowhead.org, and let me tell you a bit about this website. This is part of the ephemeral online phenomena where, and this is probably the most popular of them all, where users get on and tell their experience. They even will have diagrams or scales. You know, if you take Lyrica at this dosage, it produces this response. If you take it at this dosage, it produces this response. But a review of this website where users get on and sort of share tips produced no street names. It is considered a Schedule 5 agent because it's listed as CNS depressant. And its effect profile is very similar to that of gabapentin in that it's generally sedating, can cause a bit of euphoria. And this is easy to obtain. I haven't seen this very often misused, and I think it's probably related to its expense. However, it's going generic in 2018, and I could see the same thing that happened with gabapentin happening with Lyrica. No laugh? Tough crowd. So phentermine, this is an old drug approved in '59 for weight loss. It's a derivative of amphetamine, and the psychodynamics are very similar. So is the effect profile. Its mechanism of action works to increase secretion of norepinephrine, which is an appetite suppressant. Also has dopaminergic, serotonergic effects at clinically relevant dosages, and it's Schedule 4. In contrast, amphetamines like Adderall are Schedule 2, which in my book is kind of troubling. Street names: speed, ice, fen-phen, when it used to be in combination with another fen. Abuse potential in the literature is low. However, misuse is very well documented, and people who use this typically tend to use it in this order, either oral, then insufflation, or IV. And there are reports of all of them, but I think oral is the most common. Effect at high doses, very similar to amphetamines, in that it causes xerostomia, tachycardia, hypertension, restlessness at higher doses, agitation, serotonin syndrome at even higher doses, or in combination with other psych meds. Dr. Henson has told me about a patient that he's had present to his office without an appointment, who was red hot and mad, and when asked, "What have you been using?" his response was fen-phen, phentermine, and he said that he had gone to 3 clinics in the Tri-Cities that day and was able to get 3 30-day supplies, paying cash. This is a screenshot from a local business saying that we beat or meet all competitors' prices for phentermine. So really, it's kind of a cash type business, and anyone that wants it can get their hands on it. And the other thing that I find troubling is that it's dispensed directly from those weight loss clinics with little oversight. I myself have had patients that have active prescriptions that they could show me of phentermine, yet it has never been reported to the CSMD. Here locally, there are 75 businesses listed in the yellow pages that provide phentermine, and it's very easy to obtain. Anecdotally, Bubba Smith, fellow Texan, Super Bowl defensive end, a Super Bowl winning defensive end, phentermine is implicated in his death. I think he died of cardiac arrest and had a very high level of phentermine in his system. Next, we go on to the antitussive dextromethorphan. It's very common in over-the-counter cough and cold remedies. Approved also in 2010 for pseudobulbar affect in combination with quinidine. It's got a lot of cute street names: Dex, Triple C, Skittles, Robo. People who use it, they go Robodexing is what it's called. That's what the cool kids call it anyways. Major metabolite is dextrofen, an NMDA receptor antagonist that at high doses produces a dissociative state that's very similar to ketamine or PCP. It's also, at high doses, a non-selective serotonin reuptake inhibitor. It can be purchased at any drugstore, pharmacy, gas station, grocery store, and it's very, very cheap. And this is very popular among adolescents and youth, young adults. This has an odd profile in that its effect is nonlinear. It has these plateaus that are actually well described, for instance, on the AeroWeb website. So this chart that I have here was actually pulled from the Department of Justice website. But if you go to AeroWeb, they have this exact table posted to teach users how to abuse dextromethorphan to get the desired effect. And so there are typically 4 plateaus, and I added a 5th in that 2,500 plus serotonin syndrome or death is, it's going to result. Currently not controlled. However, the last incarnation of the Controlled Substance Act has indicated that it may be controlled down the road. Baclofen is a muscle relaxant approved in the 70s. It actually has a very similar mechanism of proposed mechanism of action to that of gabapentin. We use it in psychiatry commonly for muscle spasms and detox from alcohol, benzos, or opiates. It can be sedating at high doses, and it's often used to bridge the gap whenever a drug of choice is not available. Growing use among NMDA users, that's a mistake. No, that's not a mistake. MDMA users to counter hypothermia as a result of a 2003 study that demonstrated if you preloaded with baclofen in rats and then gave them MDMA, you averted hypothermia. And so now ravers are using it to preload before they go raving. It doesn't have a very high street value. Discontinuation is similar to that of alcohol and benzodiazepines. I had a young gentleman over at the VA who was using upwards of 300 milligrams a day of this stuff and came in for detox, and we had very difficult time detoxing him from this medication. He had intractable seizures. He had muscle spasms so severe that he couldn't get out of his own bed. It was bad. Next class of medications is another class typically used among youth. Antihistamines, typically the first generation ones, are most abused in this class, and they include diphenhydramine, chlorphenamine, dimenhydrinate, and meclizine. So they inhibit the action of histamine on tissues containing H1 receptors, reducing inflammation. They also have serotonergic and anticholinergic activity at relevant doses. And the effect is typically mild to moderate sedation at the highest recommended dosages. If you get above that, it can actually flip to stimulation, euphoria, dissociation, and hallucinations. And the troubling part about the whole drug profile of most antihistamines is they typically have a very long half-life. This can be difficult to treat overdose. They've got a lot of cute names too: Dimetabs, DQ. Cheese was a phenomenon in Dallas, and I think South Park did a spoof off of the phenomenon. But it's when diphenhydramine is used in combination with Tylenol and low-quality heroin, and it's smoked. We called it cheese because it looked like cheese. And the effect of the antihistamine, I would imagine, would be to potentiate the heroin. People who abuse Dramamine are called dramatists. I thought that was cute. Very popular among the youth. Like I said, they can be found pretty much any medicine cabinet across the country, gas stations, grocery stores, pharmacies. Taken orally, case reports of people snorting this stuff, and also I've found case reports of people using it IV with other substances. Let's see what else I've missed. So the danger with this is that at high doses, abusable doses, anticholinergic syndrome can develop and complicates treatment. I would be curious to know if anyone has any other atypical drugs of abuse that they've come across in a clinical setting. No? Any questions? Sure.
Medicines like Wellbutrin, can you use the XR form in terms of
Yes.
deflation?
Yes.
It doesn't really make any difference.
Yeah, and we have case reports of with the XR and the SA of Wellbutrin. Sure.
I think I'd like to add
That's a...
I'd like to add buprenorphine to this, particularly amongst recreational drug users that are not addicts and with a trivial amount of naloxone and no damage. Very popular. It's getting more popular. And it seems that professionals pushing it.
Right, and the reason why it was not included in the atypical drugs of abuse lecture is because it is very commonly abused, readily available. Its availability is increasing. In fact, there are lobbies in this state and the one north of us to increase the maximum number of patients you can carry on Suboxone from 100 to 500, and I think it's going to go through, to be quite honest, which is going to make it even more problematic in this part of the country.
It's a disaster.
Mm. Other questions? Thank you.
Thank you, Dr.